Hello there, I'm Megan Fix from the University of Utah, and today we are going to talk about wide complex tachycardias. I have no disclosures, but I will say that wide complex tachycardias are scary. This is one of those things in emergency medicine where you gotta just get up out of your seat if somebody tells you that someone is in a wide complex tachycardia and go see the patient. So this is the get out of your seat talk part 2. I have another talk on bradycardias, but this is going to be wide complex tachycardias. So you're sitting there on your shift and somebody hands you this rhythm strip. Of course, you are going to jump out of your seat and go see the patient. And when you get there, you're going to look at the rate and the QRS complex. So just by way of definitions, a wide complex tachycardia is really all about the number 120. So a wide complex tachycardia is defined as a heart rate greater than 120 beats a minute and a QRS greater than 120 milliseconds. So that's the definition of a wide complex tachycardia. And in emergency medicine, it's pretty straightforward. If you jump out of your seat and you go see a patient in a wide complex tachycardia and they are unstable, you're going to cardiovert them. So we have algorithms for this, and unstable means electricity. But what is unstable again? Well, let's review. There are 5 criteria based on the AHA and ACLS for unstability in the setting of a tachyarrhythmia. So you jump out of your seat, you go see the patient, and you look for these 5 things: hypotension, altered mental status, shock, so if the patient looks ashen or they're poorly perfused, and ischemic chest discomfort or acute heart failure. So if you have any of these 5 things happening, your treatment is going to be electricity for a wide complex tachycardia. And we feel really comfortable with this in emergency medicine. But the rest of this talk, I'm going to focus more on the stable patient because it's actually more complicated to think about and work up and treat the stable patient with a wide complex tachycardia. So that's where we're going to focus. We're not going to talk about narrow complex tachycardias or irregular tachycardias, because those are a whole nother situation. So here's our home base. You see a wide complex tachycardia, you jump out of your seat, you go see the patient, and you do what emergency physicians do. You get an IV, O2, monitor, crash cart, airway equipment, and your defibrillator near the patient. And you're gonna ask, is this patient stable or unstable? Is this narrow or wide? Is it regular or irregular? So we are focusing on the stable, wide, regular tachycardias today, and here are your differential. It could be ischemia, hyperkalemia, or drugs, or VTAC, or SVT with aberrancy. And then we're going to talk a little bit at the end about recurrent VTAC. So in today's talk, we are going to cover what is this wide complex stable tachycardia, what do I do with this wide complex stable tachycardia, and what if it happens again? And let's remember, your first thought is going to be, is this ischemia, hyperkalemia, or drugs, and then VTAC or SVT with aberrant conduction. So you get up out of your seat, you go see this patient, they're stable, they're talking to you, you want to get a 12-lead ECG and look at that and put the pads on, because even though the patient is stable right now, wide complex tachycardias are scary and they can deteriorate very quickly. So you see the patient, they're stable, put those pads on and be ready to cardiovert if you need to. So as you're talking to the patient, it should be like this. This should be normal for you. Get the pads on and then do your history and physical and always be ready to cardiovert. Okay, so let's talk again about our differential for what is this wide complex, regular, stable tachycardia. So ischemia, hyperkalemia, and drugs. I want you to think about that as you're talking to your patient, because the treatment is going to be different, right? If the patient is having ischemia, you're going to go to the cath lab. If they're having hyperkalemia, you're going to treat them with calcium, insulin, glucose, dialysis, and bicarbonate if they are acidemic. If it's a tricyclic overdose or some other toxicological cause, then you're going to use the antidote, and bicarbonate would be the one for tricyclics, right? So if you've gone through that list and then you get down to, is it VTAC or is it SVT with aberrancy? My summary of that question is that you want to always assume it's VTAC, because VTAC is the scary, deadly part of this. It might be SVT with aberrancy, but you want to assume that it's VTAC, because around 80% of the time, it is going to be VTAC, and the other 20% it might be an SVT with aberrancy, but it's totally appropriate to just assume it's VTAC so you can get the patient cardiology, admission, and treatment. So let's go through some cases. This is a 60-year-old with weakness. You'll notice that it's wide, it's fast, and it's actually really wide. So when you look at this ECG and you scrutinize it a little bit more, it's kind of bizarrely wide. So this is hyperkalemia. Here's another wide complex tachycardia, an 80-year-old with chest pain and shortness of breath. Now you look here, this is very regular, wide, but the patient is stable. And if you look even closer, look up here, you actually see ST elevations. And this patient is again having chest pain and shortness of breath. So this is ischemia-induced wide complex tachycardia, VTAC, because of a STEMI. So this patient needs to go to the cath lab. Now let's look at this patient. This is a 20-year-old with dizziness, wide complex, stable, tachycardic, but they're 20. And I don't know about you, but I was taught initially that young patients don't get VTAC. But in reality, this is actually VTAC. So all three of these patients are going to get admitted, and they're going to have slightly different therapies, but because you're thinking about this like VTAC, like a very severe, serious diagnosis, you're going to treat the patient. So case 1 was hyperkalemia, treat appropriately. Case 2, ischemic VTAC, treat appropriately. And then case 3, even though the patient was 20 years old, this is called right ventricular outflow tachycardia, which is a kind of VTAC. So remember, young people can get VTAC. So again, back to our main point, if you don't know what it is and it's not hyperkalemia, ischemia, or drugs, just assume that it's VTAC. Okay. Let's talk a little bit about anatomy and why this occurs. So here's our heart, our lovely conduction system. And when all things are good, we start with the SA node, sends conduction down to the AV node, and then down your bundle branches and your Purkinje fibers through the His bundle. So this is the standard way that our conduction occurs. When we talk about wide complex tachycardias, just basics of how this happens. In VTAC, you have a focus of ischemia, let's say, or a scar in the ventricle. And that sets up this fast, irritated, recurrent rhythm. And it's wide because when you go along the bundle branch fibers, the conduction is slow and inefficient. So you start from this, instead of going the efficient pathway of having the SA node communicate with the AV node and then down the bundle branches, you have the focus coming from the ventricle. The ventricle, slow, inefficient, and so it's wide, but it's tachycardic. Now that's VTAC. SVT with aberrancy, you actually have the focus of the rhythm coming from up here. It's somewhere in the supraventricular area, so this is coming from the atria. Let's say you have an AV nodal reentrant tachycardia, or you have a flutter, and that supraventricular rhythm is going down, but let's say you have an underlying bundle branch block. Let's say that your left bundle branch is out, and so then your right bundle branch is taking all of the conduction. And remember, ventricle conduction is slow and inefficient, and so even though the tachyarrhythmia is coming from the atria, it is wide. So that's what you have in an SVT with aberrancy. So wide complex tachycardia, but the tachycardia is coming from the atria. And then finally, in drugs or hyperkalemia, think about it that the entire myocardium is just bathed in potassium or in whatever toxicologic cause is happening. And so that is why the heart is just super irritated, and so the whole conduction system is messed up. And that's why it's wide and fast. Okay? Now, when I was training, I was taught that you always need to scrutinize the ECG and determine, is this VTAC or is this SVT with aberrant conduction? Remember, most of the time it's going to be VTAC, but about 20% of the time it might be SVT with aberrant conduction. So I learned about these algorithms. Now, I'll give you an example of why I think this is not the right approach. Let's say you're working. You have two patients coming in. They're the exact same age, they both have palpitations, and one of them has VTAC. The other one has SVT with aberrant conduction. So here's this 49-year-old gentleman. You do your ECG. Is this VTAC or is this SVT? Here's the other gentleman. Is this VTAC or SVT? Well, I was taught that you need to take the ECG and go through the Brugada algorithm. There's lots of steps, and it involves calipers. And then there's even more steps after you do the first set of steps. And I have to say, this was difficult for me. And in an emergency department where it's loud and things are chaotic, I would not be confident in my skills to do this correctly. This first gentleman, who I actually saw, ended up having SVT with a bundle branch block. And I didn't know that because we didn't have any old ECGs. And this gentleman had VTAC. And I'll put that little blue arrow there because based on the algorithms, the right bunny ear being larger than the left actually suggests SVT. So you are not alone that the algorithms are difficult. And the thing is, you do not want to make a mistake with this, right? You do not want to send somebody home with VTAC thinking that it was SVT. You want to admit the VTACs. So again, back to our basic premise, just assume that it's VTAC, okay? Forget the algorithms. And actually, these are the 2019 European Society of Cardiology guidelines. For the management, it says SVT, but it also covers wide complex tachycardias in this paper. And they agree with this. And this is what the guidelines state. Various ECG-based methods have specificities of 40 to 80% and accuracies of about 75%. So if you use the algorithms, you're going to mistake about 25% of these cases. So therefore, the default diagnosis should be VTAC until proven otherwise. So forget the algorithms. You can safely assume that a wide complex tachycardia that's not ischemia, hyperkalemia, or drugs is VTAC. Now, why am I making a big deal out of this? Well, it's because if you misdiagnose VTAC as SVT, it's bad. You could send home somebody with a deadly diagnosis, and treatment for SVT is different. If you give somebody with a VTAC typical SVT meds, like diltiazem, for example, you can really make things worse. On the other hand, if you misdiagnose SVT as VTAC, well, it's okay. You might do a little bit of an extra workup, but you won't harm patients, and you won't send home deadly diagnoses. So no ECG algorithm is 100% accurate. Just assume that if it's not ischemia, hyperkalemia, or drugs, it's VTAC. All right, so we have covered what is this wide complex tachycardia. It's going to be ischemia, hyperkalemia, drugs, or VTAC. Now let's talk about what do I do with this wide complex tachycardia. So the first question that comes up here is, can I use adenosine? We use adenosine all the time for narrow complex tachycardias that are regular, SVTs. So can I use it in a wide complex, stable, regular tachycardia? Well, you can. And I'll give you this example of the gentleman we talked about before. So this gentleman came in to see us. He was stable, normal blood pressure, wide complex tachycardia, as you see here. He had hypertension and hyperlipidemia, but no old ECGs in the system. So we did not know if he had an underlying bundle or not. And this was many years ago, and I called cardiology and they said, well, he's stable. It's probably SVT. Let's give him adenosine. So we gave him adenosine and he converted. And now you see this ECG. And it's quite different. He's now in a sinus rhythm. And again, the patient had a few risk factors, and this is a different looking ECG. It's more narrow complex. So we admitted him. And what they found out, well, was this VTAC or was this SVT? So they did an EP study. He did have an SVT, and it was a rate-related bundle branch block. And then he also had 3-vessel coronary artery disease. So it was really good that we admitted the patient anyways, even though he had SVT, because he got a CABG. So this is another reason to just assume wide complex tachycardias are VTAC and admit the patient to get a workup. Here's another one I saw just a few months ago. This is a 66-year-old male with dyspnea for 5 days. Very regular, stable, wide complex tachycardia. He also had no old ECGs in our system. This looks like a right bundle branch block, and it's really fast. And then you go into the room and you see 150, 151, 150, 150 for his rate. And anytime that I walk in and I look at the monitor and it is super regular, I always think about, you guessed it, a flutter. So this is a time you can also use adenosine. So we gave this patient adenosine and look what we saw. The flutter waves are much easier to see. So this wide complex tachycardia was atrial flutter with a right bundle branch block. And this was underlying for the patient, and he always had this. So this is another example of using adenosine. And the AHA guidelines from 2020 also state that you can use adenosine in stable wide complex tachycardias, only if, this is very important, it's regular and monomorphic. You do not want to give adenosine to irregular wide complex tachycardias because that could be WPW, and then you could really make the patient deteriorate, and you don't want to give it to polymorphic VTAC. So this is what they state. Adenosine is relatively safe. It's quick on, quick off, really, really low side effects, except for the feeling during adenosine. So adenosine is relatively safe for treating a hemodynamically stable, regular, monomorphic, wide complex tachycardia of unknown type. And as an aid in rhythm diagnosis, so we can aid you, although its use is not completely without risk. Now, this is important. Not completely without risk. I think of this as you don't want to use adenosine to diagnose the patient, because remember, we're assuming that this is VTAC, and I'll give you some examples in a moment. Here are the recommendations from the AHA guidelines from 2020. You'll see that they say that you can use adenosine, but it should not be given to unstable, irregular, or polymorphic tachycardias. The ESC guidelines also state that you can use adenosine. You'll see here, if the patient's stable, you can try vagal maneuvers first, and then if ineffective, you can try adenosine. So here's the problem. Adenosine has risks because adenosine we use for SVTs all the time, and we've seen that it doesn't always work. But then the thing about adenosine is that it actually does work for some VTACs. About 5 to 10% of the time, if you give adenosine to a real VTAC, it will convert the patient. So again, if you assume that that adenosine working means that the patient had SVT and you send them home, you might send home 10% of patients with VTAC, which would be bad. So don't use adenosine to diagnose SVT if it works. Think about it like you wouldn't give adenosine, think about it like a GI cocktail for ACS. I learned this from Amal Mattu. So in ACS, right, we all know that if you give a GI cocktail, some of those patients are going to feel better. But they really have underlying ACS, and you're not going to send them home. Similarly with adenosine. If you give adenosine to a wide complex tachycardia and they get better, don't assume that it is SVT, the more benign condition. All right, so adenosine is probably safe, but don't rely on it to diagnose SVT. Okay, moving on to our next question in what do I do with this stable wide complex tachycardia? What treatment do I use? There are some options, but first and foremost, remember, you got up, you went to see the patient, and you put the pads on. So even though this patient is stable, you can always use synchronized cardioversion. And I think we tend to not reach for this because it seems very invasive, but it is safe, it is effective, and even if the patient is stable, you can always do this. Give a little sedation and obviously consent your patient, but you always have this available to you. And because you put the pads on, it's right there. Just make sure that you are using synchronized cardioversion. So you have cardioversion available to you. You also have adenosine, as we've talked about. And then generally, there are these other medications that you can use. amiodarone, lidocaine, procainamide, and sotalol. A lot of us use amiodarone, and that's fine. But what is actually the most effective for a wide complex regular tachycardia in the ED? It's actually procainamide. But let's talk about the guidelines. So the AHA says that you can use either amiodarone or procainamide or sotalol. And they, in the 2020 update, gave all of these medications a 2B recommendation. Okay? This is the recommendation here, 2020. The AHA says that you can use any one of these meds for your wide complex stable tachycardia. But I have a little bit of an issue with this just because of some recent studies, and I'm going to highlight one. This is the ProCameo study, and it came out about 5 years ago, and it's really important to know about in this domain because essentially what they did is they did a randomized controlled trial of amiodarone versus procainamide for stable wide complex tachycardias. And they basically gave half of the patients procainamide and half of the patients amiodarone, and they looked for any adverse events, so MACE within 40 minutes, and they looked to see if it actually worked. Did it terminate the tachycardia within 40 minutes? And what did they find? Well, procainamide actually did better. There was less adverse events with procainamide than with amiodarone, and procainamide worked better to terminate the tachycardia within 40 minutes. You'll see 67% with procainamide and 38% with amiodarone. So procainamide is more effective and safer than amiodarone for patients with a stable wide complex tachycardia in the ED setting. So it's interesting that the AHA guidelines say that they're all the same. The European guidelines, on the other hand, from 2019, they actually state here that procainamide receives a 2A recommendation and amiodarone receives a 2B. So they're saying that probably a little more recommended to give procainamide, and amiodarone is also appropriate. One thought may be because amiodarone tends to work a little later, whereas procainamide works again more within that 40-minute timeline. And so if you're admitting the patient, cardiologists tend to like amiodarone for other reasons. So what do? Well, remember, we're admitting all these patients, right? We're admitting them because we're assuming that it's VTAC. So my personal approach is that if the patient's stable, I talk to the cardiologist who's admitting the patient, we talk about the meds, and we decide on what they would like to do. If you are going to do procainamide, though, make sure the patient has the pads on, you've already done that, and good IV access, because if it goes in too fast for the infusion, the patient can have hypotension, a long QT, or widening QRS. So just make sure that you're monitoring the patient closely and slow down the infusion if you notice any of those. So what do I do for wide complex, regular, stable tachycardia? You can use adenosine with caution, right? You're not going to diagnose SVT based on it working. And then for the stable VTAC patient, you could use amiodarone, procainamide, or sotalol, but procainamide is more effective and safer based on ED studies. So finally, I do want to spend a little bit of time talking about what if the patient keeps going in to this wide complex tachycardic rhythm? What if it keeps happening? And they have recurrent VTAC. Well, there's also a little bit of different agents to use for that. So here's a case. This is actually a recent case from last month here at our hospital. Our resident Ben and the attending Chris sent me this ECG. So this patient was a middle-aged man who came in with recurrent palpitations and near syncope. And he was stable, sitting there talking to them. And on the monitor, as you see here, he was going in and out of this wide complex tachycardic rhythm here. And then intermittently, he would have these narrow sinus beats. And the patient would feel them when it would come on. So he kept going in and out, and they have multiple ECGs showing this VTAC and then some sinus. So what did they do? Talk to cardiology, talk to pharmacy, and talk to EP. And it was so interesting because our ED folks wanted to give procainamide based on ED studies. Pharmacy wanted to give lidocaine. Cardiology wanted to give amiodarone, And the electrophysiologist, the EP doctor, wanted to give propranolol. So there's lots of options here. What did we do? Well, we ended up giving the patient amiodarone, and he got admitted. And it turns out that throughout his admission, he still had multiple runs of this, and they determined that this was electrical storm, and they gave the patient beta blockers. Now, I want you to remember this. It's rare, but electrical storm is defined as more than 3 episodes of sustained VTAC, VFib, or appropriate shocks from an AICD. And the patient comes in and they're saying, I've had multiple shocks, and you review the pacemaker, and that's what's happening. Think about electrical storm, okay? More than 3 episodes of one of these rhythms. The causes are many. There's ischemia, drugs, thyroid, electrolyte issues, especially hypo-K and hypomag. And I want to highlight this increased sympathetic tone. The patients are going in and out of this, and oftentimes they have a lot of sympathetic tone on board. There's an article at the bottom that's a really good review of electrical storm that I highly encourage you to read. But the increased sympathetic tone is really important because we want to decrease that to help stop the patient from going in and out of VTAC. So the treatment is different. You want to avoid epinephrine because epinephrine will increase your sympathetic tone. You always have cardioversion on board or available to you, as we talked about before. And the article goes into different categories of this, which gets kind of complicated, but for our purposes today, if it's monomorphic, you have amiodarone at your disposal. And remember, this may be another reason that cardiologists like amiodarone, because it does have some beta blocking properties. You can also use lidocaine, and then you can use a non-selective beta blocker like propranolol or esmolol. Beta blockers will help decrease that sympathetic tone and get the patient out of this recurrent cycle of VTAC. And I want to make mention of this because it's not typically what we think about for VTAC, right? Beta blockers. But if the patient keeps having this happening, think about electrical storm, think about beta blockers, because that could really be the end treatment that's going to help your patient. And with the patient we just talked about, they sent that gentleman home on propranolol, and he's doing quite well. So remember electrical storm, you may need to reach for a different class of medication in beta blockers. So now we talked about what if this VTAC keeps happening. Think about electrical storm and consider amiodarone or beta blockers. Okay, so let's summarize what we learned today in regard to the stable, wide complex, regular tachycardia. Once you determine that it's not ischemia, hyperkalemia, or drugs, it is going to be VTAC until proven otherwise. This will be safer for your patients, and you won't send home deadly diagnoses. You're going to use caution if you use adenosine. Both the AHA guidelines and the European guidelines say that you can use adenosine in a stable, regular, wide complex tachycardia, but use caution. Don't use adenosine working to diagnose SVT. Reach for electrical cardioversion or procainamide as the most effective therapies for stable VTAC patients. You can also use amiodarone or sotalol based on the AHA guidelines. And if your patient keeps going in and out of this, think about beta blockers and recurrent VTAC. That's called electrical storm, and remember, it's due in some parts to increase sympathetic tone. So giving beta blockers can really help combat that. So our stable, regular, wide complex tachycardia summary. If it's not ischemia, hyperkalemia, or drugs, just assume it's VTAC. Simple. And don't forget that young patients can also have VTAC. You can try adenosine, but not to diagnose. You want to have electrical cardioversion ready with the pads on your patient. Reach for procainamide as the most effective therapy in the ED, and think about electrical storm. Thank you so much, and here's my email if you have any questions.